The last category of antidepressants we're going to talk about are many times just lumped in with SSRIs and SNRIs because they work in a similar way, but there are enough differences with them that sometimes people kind of set them aside as being in another category. On page 198, we see that they start off with atypical antidepressants. So our prototype drugs would be Wellbutrin, Surzone, and Effexor, and you might have heard of any of those. Bupropion is Wellbutrin, Nefazodone is Surzone, and venlafaxine is Effexor. In the ATI book, these drugs are briefly discussed on pages 83 and 84. Now, I mentioned an increase in energy being one of the first improvements that you see when you first start on an antidepressant. It's not always going to be an elevation in mood. Sometimes it's going to be just the patient feels more like getting up and doing anything. So when you hear that an antidepressant is linked to increased suicide risk, it's not that it makes the depression worse or that it puts the thoughts of suicide in somebody's head, but what happens is all of a sudden they feel an increase in energy and they actually feel like doing something that requires some exertion. And sometimes this might lead them to carry out a suicide plan that they didn't really have the energy or the motivation to carry out before. So the only thing we can do is educate them about that. Just tell them, you're not going to start feeling better right away. It could take 3 weeks, it could take a month. You might notice that you have increased energy, but don't worry if you feel more energetic, but your mood doesn't elevate. That will come with time. Hang in there. And we just need to educate people whose children are taking antidepressants, adults and older adolescents who start on antidepressants. Just warn them that the energy is going to improve before the mood does. Wellbutrin or bupropion is often used for smoking cessation. Sometimes you see that used more for encouraging smoking cessation rather than depression. Any of these miscellaneous antidepressants should not be taken at bedtime because they can cause a lack of sleep. They can raise energy. They should be given with food to cut down on the risk of GI problems. If the person has an eating disorder, many times an antidepressant will be prescribed for them because anorexia can be associated with depression. They can be very tied together. But you don't want to give an anorectic patient a drug that is going to increase their physical anorexia. So watch for that. You also want to watch for agitation or other unusual behaviors that could indicate serotonin syndrome. Sometimes there'll be a change in mood, or the person will become overly stimulated to the point where they might become a little on the manic side. So we want to warn patients about that and watch for that possibility. I want to talk briefly about mood stabilizers, and we talk briefly because there's really only one mood stabilizer that we are going to discuss in this book. We don't talk a whole lot about bipolar disorder because bipolar disorder generally is characterized by episodes of depression that are alternated with episodes where the person feels kind of on an even keel or fairly happy but still in control of themselves, all the way up to mania. And mania leads to something that can sometimes mimic psychosis. The person can kind of lose control of reality. So we're going to discuss, we've already discussed antidepressants, so we're going to discuss a drug called Lithium, which is considered to be the drug of choice for the manic phase of bipolar disorder. Lithium comes under different names, but the name that, one of the names the book chooses is lithobid. Lithium is a chemical element that is naturally found in the brain. We all have a lithium level. But people with bipolar disorder are thought to either not respond to the lithium that their brain already has, or they don't make enough of it. They don't really entirely understand how lithium works, but they know that it affects how sodium goes in and out of the nerve endings, and sodium going into any of the cells can lead to increased message transmission. And so the sodium sometimes leads to the person taking up more serotonin and norepinephrine. They might not necessarily need more serotonin and norepinephrine if they're entering a manic phase. So this, in contrast to antidepressants that slow down reuptake of serotonin and norepinephrine, this speeds it up a little bit. It encourages the neurons to take up these neurotransmitters and recycle them and inactivate them. It's considered to be a mood stabilizing drug. It just kind of puts the person on an even keel. It doesn't make them too happy, and it isn't supposed to make them more depressed. On page 204 in our book, we see box 10.6 that tells symptoms of mania. And so if you read over those, you can see that they do sometimes cause sort of a lack of contact with reality. Bipolar disorder that is characterized by acute manic phases responds pretty well to lithium, and the lithium can help prevent recurrent manic episodes and can kind of keep the person on an even keel. Lithium is different than the other psych drugs we talk about because it doesn't have sedative effects. It usually is not going to make the person's central nervous system more depressed, and it doesn't cause euphoria like opioids and that one anti-epileptic drug we talked about can do. It just stabilizes the mood. Now, the only drawback to this is that there's kind of a narrow therapeutic window. It doesn't take much for a therapeutic range to get out of therapeutic range and get into toxic range. On page 205, we see some safety alerts when it comes to lithium, and we see symptoms associated with elevated lithium levels, and you can see that they get more and more and more severe. The therapeutic range of lithium is considered to be about 0.8 or 0.8 of a milliequivalent per liter to 1.2 milliequivalents per liter. That means if they took a liter of your blood, they should find 0.8 to 1.2. Once a person is settled on lithium, they want them to stay generally between 0.8 and 1. Going too far over 1.2 can lead to problems. Our natural lithium levels without any medication usually tend to run 0.6 to 1, which does pretty well for the average person, but not so much the person who is bipolar. Signs and symptoms of lithium toxicity: it can start off with nausea and vomiting. The person might develop diarrhea. They'll get very weak and drowsy. They'll start to have hand tremors at first and clumsiness. And so older adults naturally are going to be more at risk because of liver and kidney changes. Dehydration can also increase that risk. So make sure you read about lithium toxicity and signs and symptoms so that it can be avoided.